This is the fourth video in the sequence of 15 that I'm doing for our students joining us in Winchester and Basingstoke to study pediatrics. In the first video, I discussed some of the differences that you will encounter and the basic skills that you need to be thinking about. In the second video, I thought about an approach to the history taking process in the first year of life. And in this third, we thought about how we might examine and assess a very sick or potentially unwell 2-year-old. I'm hoping that by now you've put some of these skills into practice and started practicing taking a history and examining in small children, and then thinking about their growth, their development, and how we're going to think about the differential diagnosis of whatever problem they're presented with. In this fourth video, I'm going to take us right back to the neonatal period, in other words, the first 28 days of life. This is a specific specialty, and I'm not going to be teaching you about how to be a neonatologist. That would clearly be silly and unnecessary and not helpful to your learning. However, clinicians who might be seeing children in the first month of life have to be able to have a thorough, structured approach to assessing these children. This might be a child who's maybe only a few minutes old or a child who's up to 4 weeks of age. Much of what I talked about in the first 3 videos is still applicable. In other words, we have to have a structured approach to thinking about congenital disease and acquired disease. But I hope you can understand now that the boundary between these two distinctions is quite blurry. There will be acquired diseases, such as an infection that was acquired in the womb that became manifest when the child was born. And there will be congenital problems, such as a genetic problem that might only present in the first few days or hours or months of life. So the distinction between congenital and acquired becomes a little bit blurry, but can still be a useful one to make. What is more important is that we have a structured approach to thinking about the pregnancy and how that pregnancy went, both in terms of the mum's health and her situation medically and socially, screening tests or other investigations that she had during her pregnancy. We need to think about the labor and delivery, and we need to think about how the gestation and why the mum went into labor, whether it was spontaneous or induced, and whether there were any complications or whether any assistance was required. We have to understand how the baby was delivered and in what condition they were delivered. In other words, they may have recorded APGARs, which is not a very useful thing in terms of resuscitation, but will give us some sort of an idea of how that child was in the first few minutes of life. More usefully, when we're taking a neonatal history, we can ask some very specific questions. We can ask about this child's feeding. I talked quite a lot about growth in the first 2 videos. And in this video, I'd really like to think more about infant feeding. Most children do not require anything other than human breast milk for the first 6 months of life. Therefore, our default should be that most babies will receive nothing other than human breast milk from their mum for the first 6 months of life. Now, there will obviously be a whole range of reasons why this might not happen. The family may choose not to breastfeed, and that's absolutely fine. That is their choice. The family may wish to breastfeed, but for practical reasons, this doesn't work out. Or there might be other health reasons that mean that this doesn't happen. And therefore, we should not be prejudiced against parents who are formula feeding their baby for whatever reasons. But we also need to be mindful that the evidence is that breastfeeding is best both for mums and babies where it is practically possible and all else is equal. And we should support mums in breastfeeding their babies wherever possible. At some point between 5 or 6 months of age, parents will start to choose to bring in non-milk based feeds, in other words, weaning. And we need to know a little bit about that as clinicians so that we can take a history in terms of what foods were introduced when and how that is going in. But really, for a neonatal history, it is all about milk-based feeds. We need to know what kind of formula, if it's not breast milk. We need to know how much and how well this has been tolerated. And a lot of the information that we're going to get in the first few days and weeks of life is going to be around feeding. Because if a child is neurologically able to feed well, and if that child does not have an A, B, or C problem that stops them from feeding, this is very encouraging. If this child is waking for feeds, taking a good feed, satisfied by feeds, gaining weight, going to the toilet to open its bowels and pass urine normally, then this is incredibly reassuring. Conversely, any problems with feeding will really manifest quite quickly in neonates as a potential problem. The child might become hypoglycemic, dehydrated, become more unwell, and therefore the ability to take a thorough, structured feeding history is crucial when we're thinking about the neonatal period. Similarly, there are other problems that might present in the first few days. We need to think about a congenital or acquired infection. We need to be able to think about jaundice and have a structured approach to jaundice. And we have to think about other things such as breathing problems or other issues during the neonatal period. Full stop. There are other things that we need to be able to think about in terms of routine tests or screening that we do in the neonatal period. We will do a newborn physical examination, what we used to call the baby check. We will have a day 5 to day 7 heel prick looking for congenital illness. And some babies, we will do hip screening in addition to the newborn check, or we will refer to the eye doctors or for a hearing screen, or we will arrange for a cardiology review because of concerns about a murmur. What I hope you can see from this is that neonatal medicine is really about two things. It's about the care of a relatively straightforward, normal, healthy infant and the tests, the screening, the questions that we ask. And then it's about thinking about situations in which something might have gone wrong. It might be going wrong because of prematurity. I would expect you to attend at least one neonatal ward round and to have a think about some of the problems that prematurity presents. It may be that there are problems relating to the labor or delivery and that the child is dealing with the complications relating to that. And it may be that there were problems in the first few hours or days or weeks of life that mean that this child comes to medical attention. We do not expect you to be very well versed in all matters relating to neonatal medicine. But what you do need to do is make sure that you have some basic understanding of an approach to a potentially sick child, either because of prematurity or because of concerns that have come to light during the period of labor or delivery or through screening, or because the child comes to medical attention with concerns such as poor feeding, jaundice, breathlessness, or concerns about sepsis. We have to have a structured approach to the child who just comes to us just not right. It doesn't sound very scientific to talk about a floppy baby, but we will see babies where the parents are just concerned because the child's not right and a bit floppy and a bit lethargic. And we have to have a structured approach to this. And I would like you to watch this video, maybe watch it again, take some notes, go on a neonatal ward round, spend some time with the neonatal team, and think about these things in a bit more detail. Thank you.